Gastroenterology is a broadly tested topic on Step 2 for both adult and pediatrics. This is good for you because the testers go into slightly less depth because there are so many different pathologies and organ systems to cover. The goal is to know what counts. We're going to start with jaundice, and then we're going to cover 3 different atresias: esophageal, duodenal, and choanal, pyloric stenosis, and then Hirschsprung's disease. Jaundice is an incredibly common topic in medicine, and pediatrics is no different. It can also be complicated, so we're going to focus on the facts and organize the information so it's easier to digest. Specifically, start with the fact that jaundice is a symptom. It's a symptom of hyperbilirubinemia, excess bilirubin. Now that occurs when production eclipses elimination. There can be different types of hyperbilirubinemia, indirect versus direct, and there can be different causes of increased production or decreased elimination. You can have an increased breakdown of red blood cells, or you can have a blockage in your biliary tree. All of these can lead to different types of hyperbilirubinemia or related to dramatically different diagnoses and require very different interventions. So let's start with some of the basic tenets and facts of hyperbilirubinemia in pediatrics. The first is jaundice is incredibly common in newborns. It happens in almost 2/3 of newborns that are term and have no other problems with them. Transient hyperbilirubinemia, which is discussed in another lecture. There are instances, though, when jaundice is never normal in a kid. So these are some of the red flags you should be on the lookout for. Any jaundice of any type that occurs in the first day of life, whether it be direct or indirect, warrants an evaluation. Anytime the jaundice is a direct hyperbilirubinemia, that warrants an immediate evaluation, and that's regardless of age. So we have one which is regardless of type if it's within the first day. We have one that's regardless of age if it's a direct. And the third tenet is any hyperbilirubinemia that's basically occurring in someone after the first 3 weeks of life is going to require some evaluation. Because there are other types of jaundice. There can be some breast milk jaundice, there can be breastfeeding jaundice, there can be transient hyperbilirubinemia, which are all fairly benign and don't need to have anything more than watchful waiting. But once it's after 3 weeks, you're not going to be seeing breastfeeding jaundice or breast milk jaundice, and you need to evaluate it regardless of type. Next, jaundice is never common in children. So this sort of goes with our last red flag, that anytime it's someone greater than 3 weeks, you should also keep in mind that that includes anybody after 3 weeks, a 5-year-old, a 10-year-old. Jaundice is not normal in kids, so regardless of type, you should always look into it. And know that physiologic is not necessarily benign. Just because jaundice, there's a physiologic explanation for the jaundice occurring, jaundice and hyperbilirubinemia in and of itself is a problem and needs to be looked into, because too much bilirubin in the system can lead to a devastating disease called kernicterus, and that is when you have staining of parts of the nuclei in the brain, particularly the basal ganglia, the subthalamic nuclei. These can lead to an irreversible bilirubin encephalopathy. We're now going to spend some time building an algorithm for the approach to jaundice in a child. It's going to be a little different than some of the algorithms you see other places, because this is intended to focus and highlight on the key divergences in treatment and management that are important to answering questions on your test. So pull out an extra piece of paper if you have one, or you can always come back and do this later and just listen for now. The idea is this will provide an outline for you to copy down and add to as you finish up pediatric sections and finish up other sections as you review for Step 2. It's going to give you the major split-offs in management and diagnosis. So Step 1, in a pediatric patient that presents with jaundice, the question is this a child or a newborn? That's a pretty simple divergence, because if it is a child, that means you immediately need to evaluate, because no matter what type of hyperbilirubinemia it is, in a child, you need to work it up. It means it's likely not a physiologic benign cause. And when I put this evaluate box in, that doesn't mean there's one term that goes in there. It means that when a child has hyperbilirubinemia and or jaundice, there needs to be a differentiation between direct and indirect. Is this a child that possibly has a duct blockage and will likely have a direct hyperbilirubinemia, or is this a kid with a history of hemolytic anemia that's likely to present with an indirect hyperbilirubinemia? But the idea is that in place of this evaluate box,
you'd actually have a whole another split off, and another tree and web would take place from here. The next question is that if this is a newborn, is this newborn less than 24 hours of life? Because if it is, as we've said, you need to evaluate immediately. Whether it's direct or indirect, any hyperbilirubinemia that happens in the first day of life is bad and needs to be evaluated. If it's greater than 24 hours of life, so this is a newborn that's more than a day old, then the question is, now we have to ask, is this direct or indirect hyperbilirubinemia of a newborn? Now at this point in the algorithm, with a child that's over than a day old, we focus on direct versus indirect hyperbilirubinemia, because in the newborn over a day, but less than 3 weeks, there is an important difference between direct and indirect hyperbilirubinemia. And you should make the mental effort to divide these completely in your mind for this age group, and probably for all types of hyperbilirubinemia. Now, one of the goals in establishing the difference between direct and indirect hyperbilirubinemia in a young child is that when do they need to be evaluated? Now, as we've said, likely anytime there's a direct hyperbilirubinemia, it doesn't necessarily mean that something bad is happening, but they have to be evaluated. There's going to workup that needs to be done, you're going to order ultrasounds, more blood tests, etc. But the idea is that indirect hyperbilirubinemia is a little more complicated, because depending on the age of the child, they might not need a more thorough evaluation. So there's a couple of steps you can add to your algorithm that are relevant to your test on what's the best next step in management. Now, if it's an indirect hyperbilirubinemia, the first question you should ask is this child sick appearing or not? Because whether it's hyperbilirubinemia or any other diagnosis on the test, a sick kid or a sick person gets evaluated. No matter how many signs or symptoms that might indicate a benign cause, sick people get worked up. The next question is this kid over 2 weeks of life? If it is, they likely need an evaluation. Now, the difference between the evaluated child that's over 2 weeks of life and the evaluated child over 3 weeks of life is that if they're over 3 weeks, it's almost certain to be a pathologic cause. Now, it's less certain that between that second and third week of life to be a pathologic cause of hyperbilirubinemia, but they still need to be evaluated at 2 weeks of life. So that gets us down to probably the more relevant aspects of how this will show up on your test. And that's in the kid that is under 2 weeks of life, and it comes in looking well, but it's jaundiced. Now, if they're in the second week of life, we think of breast milk jaundice. Now, this is exactly what it sounds. The cause of it is largely unknown, but what you do in a kid that presents, a healthy kid, in the second week of life, with jaundice, you just stop giving them breast milk, and you monitor them for 2 days, and you monitor their bellies, and you just give formula. So that's the simple answer on step 2. Kid comes in, that is 10 days old, jaundiced, has been feeding well. You just stop breast milk, put on formula, and if they get better, it was breast milk jaundice. That is a reasonable course of action because they're well appearing. And if their bilirubins aren't unbelievably high, then you don't need to worry about therapy specifically to treat the hyperbilirubinemia. Now, if they're under a week old, then it's a slightly more complicated. You have to differentiate between transient hyperbilirubinemia of the newborn and breastfeeding jaundice. Now, they're both sort of benign physiologic causes with different underlying things. So transient hyperbilirubinemia has to do with the turnover of fetal hemoglobin that peaks in the second or third day, maybe peaks on the 5th day if it's a premature baby, and then goes away all by itself. But breastfeeding jaundice has to do with poor feeding habits, and that's why we give proper breastfeeding instructions to mothers, because if there's bad feeding habits, that can contribute to dehydration, which is believed to contribute to breastfeeding jaundice. So if a well-looking baby comes in, relatively well-looking baby, comes in with jaundice under a week, the first step to do is probably to observe the mother's breastfeeding habits, because if they're poor breastfeeding habits, then you fix that, and maybe that'll fix the jaundice. Be clear then to not confuse breast milk jaundice with breastfeeding jaundice. You should probably, use the phrase poor breastfeeding jaundice. That'll help you remember that the breastfeeding jaundice is related to poor feeding habits, which leads to dehydration, which leads to jaundice. Now we're going to focus on the underlying causes of direct hyperbilirubinemia in kids. Now, as we've said, direct hyperbilirubinemia are always worked up. And the juncture here is to differentiate between intrinsic causes of hyperbilirubinemia, meaning the liver cells themselves have something going on with them that's decreasing their ability to move the bilirubin from the blood and into the ducts to move it into the small intestines and out the body, versus a physical anatomical obstruction within a normally functioning liver. And the two differentiations we see, so hepatocyte, so infection, sepsis, endocrine and genetic abnormalities, these can all affect the hepatocytes in such a way that they don't move bilirubin from the cells and into the ducts appropriately. This is different from obstruction, so a non-septic looking baby that comes in with ridiculously high bilirubins, particularly direct, with a direct fraction, you worry about biliary atresia. Putting this all together, you should get a skeletal diagram that closely resembles this. The framework provides just the basic junctures where evaluations and diagnoses take place that we've just discussed. And the purple arrows indicate places where we mentioned that an evaluation should take place. So hopefully, as you go through your pediatric section and the rest of your studying for step 2, you can put something next to these arrows like differential diagnoses, best initial tests, best management steps, so that you have a diagram that really allows you to pull all of jaundice in a child together. And it'll actually end up being much bigger than this as you add to it. Now, all this stressing of jaundice and bilirubin has to do with one thing, and that's kernicterus. Kernicterus is related to the toxicity of bilirubin in and of itself. Regardless of whether the cause of the jaundice and the hyperbilirubinemia is a direct or indirect, or whether it's pathologic or physiologic, enough bilirubin in the system can lead to a terrible condition of kernicterus, which is a bilirubin encephalopathy. Bilirubin encephalopathy is when you have deposition of bilirubin in various parts of the brain, particularly gray matter nuclei, the basal ganglia, the hippocampus, and the subthalamic nucleus. These are incredibly important aspects of the brain, and they lead to multiple neurological abnormalities. There's no treatment for kernicterus once it's already taken place. So the point is to actively and aggressively prevent it, and that's through various measures that are given to newborns when a high bilirubin is seen, and that's usually phototherapy versus exchange transfusion. Now, exchange transfusion is directly just pulling out the bilirubin, but phototherapy is when you put the little babies under lamps, and that the photons actually lead to the transformation of the bilirubin so it can be naturally eliminated. Let's move on to atresias, which in total are not a hotly tested topic on step 2 outside of the management questions. So we're going to simplify the discussion by consolidating the important information onto one table for all three. The 3 main atresias you're likely to see, if any, are esophageal, choanal, and duodenal atresia. Now, esophageal atresia is a blind esophagus. The bottom line is the esophagus starts and it ends, and this usually occurs far away from the stomach and closer to the top in the proximal half of the esophagus. This shows the 4 types of esophageal atresias, and you don't need to get hung up on all 4 and just focus on the first one, because it makes up as much as 90% of the cases of diagnosed esophageal atresia, which means the other 3 combined make up at most 20%. So they're unimportant for you, they're unimportant for your test, and I think you should focus on just the first diagram, type A. Now this shows the proximal half of the esophagus ending blindly. The distal half of the esophagus is actually attached to the trachea. Now this is perfectly fine in utero because the baby in both its lungs and throughout its GI tract is actually swallowing all sorts of amniotic fluid. So there's just amniotic fluid everywhere. And so it doesn't matter that the stomach and the lungs are connected in utero because they're all filled with amniotic fluid anyways. But after birth, this becomes a major issue because obviously the kid can't feed, and then it risks aspirating gastric juice into its lungs and can lead to problems there. esophageal atresia, is when there's a blind esophagus. That means the esophagus dead ends and does not connect with the stomach as it's intended to. It could mean that the esophagus is attached to the trachea and or the trachea is then attached to the stomach, but esophageal atresia and all the many types that it comes in, all the varieties and flavors, ultimately means that it doesn't directly connect to the stomach as it should. This is intimately related to how it presents, which is with the very first feed, there's frothing, cough, and bubbling because that food or the milk or the formula goes into the esophagus, has nowhere to go, builds up, eventually spills back over, and then comes down to the trachea where the child is respiring, hopefully normally, and that air pushing up with the formula or the milk turns into a bubbling, frothing milk mix. Now, if enough food, if enough formula milk goes down into the airway and inhibits oxygen exchange in the lungs, you get cyanosis and respiratory distress when they're feeding. So when they're feeding, because the food has nowhere to go except ultimately via gravity through the airway or into the lungs, they can have severe respiratory distress with feeds. But they're normal at rest. When they're not eating and they're just sitting there, they respire fine. There's nothing inherently wrong with their airway. So they have no respiratory distress at rest. And I point this out because this isn't going to be true of the next atresia that we speak about. But there's no respiratory distress with esophageal atresia. There's only respiratory distress with feeds. Now, the best initial test, the first thing you should order is you should get a chest x-ray because you might be able to see whether there's inherent abnormalities with the airway or whether the esophagus discontinues. You don't want to throw these kids under an MRI or a CT because CTs best see bone. There's really no bony abnormalities here, and it's soft tissues, and you can usually see the absence of the esophagus connecting with the stomach through a chest x-ray. And then a major concern with these kids is aspiration pneumonia, and that's because fluid contents and mouth-floral contents that go from the GI area into the lungs, that's going to cause a risk of getting anaerobic bacteria into the lungs, and that can lead to an aspiration pneumonia, which can be necrotic or abscess-like, but it tends not to be interstitial, but it tends to be more focal. And to link this with your ID knowledge, you have to think, well, given that anaerobic bacteria are responsible for aspiration pneumonia, what antibiotics are you going to put these kids on? And so think of treatment for aspiration pneumonias with penicillin-like antibiotics. You're also going to need a beta-lactamase inhibitor, so amoxicillin clavulanate and piperacillin tazobactam. With or without clindamycin are the antibiotics of choice.
Now, choanal atresia is a situation in which there's a membrane that remains between the nasal airways and the pharynx, as in that place, that space where your soft palate is, and above that where your nose is, and then below into the pharynx. This is not an issue during gestation. In utero, this doesn't affect the baby at all. Why? Because there's the umbilical cord. Oxygenated blood is coming from mama to the baby and circulating through. But the moment that baby is born and that cord is clamped, there immediately becomes a huge issue. And that's because newborns are obligate nose breathers. They don't breathe through their mouth. They feed through their mouth and they breathe through their nose. That allows them to feed on the breast or on a formula bottle, and then they can breathe through their nose while they're taking breaks. But this obligate nose breathing issue becomes really a problem if there's a membrane separating the nose from the pharynx. So that is what makes choanal atresia a distinctive feature between esophageal atresia, is the presence of respiratory distress. So if you have a newborn and they're turning blue at rest and then they start to cry and they pink up a bit, that's a pathognomonic sign of choanal atresia, because that pinking up while they cry is they're obviously breathing while they're crying. So crying, they become mouth breathers, but at rest, they're nose breathers. So they'll often start to turn cyanotic, and then they start to cry because they're uncomfortable, and then they pink up, and that episode it just repeats itself. So the best initial test you want to do is try and pass an NG tube through the nose. If you meet resistance on one or both sides, that can start to give you more evidence that choanal atresia exists. But the most diagnostic test that NG tube doesn't confirm the presence of a buccopharyngeal membrane. So you're going to confirm it with the most diagnostic test, which is a CT scan. And the reason that is because a lot of these sort of remnant buccopharyngeal membranes that cause choanal atresia have bone in them, and CT sees bone better than an MRI. We like to do less invasive things, and we like to give MRIs to kids, but you got to get a CT if you're concerned about bone being present, because that will guide the surgical therapy to remove this. The first step in management, think about this. You don't need to place an IV. They're not dehydrated. You don't need to get antibiotics because you're not worrying about sepsis. This kid's in respiratory distress. So the first step in management is securing the airway. You intubate if you need to. You secure something in the nose to keep to make sure that they can have access to air. Securing the airway, whatever is necessary, is the first step in management of these kids with choanal atresia. Now, duodenal atresia. Duodenal atresia is fairly straightforward. It occurs when there is failed canalization of the duodenum during development. This creates an abrupt blockage in the digestive tract, just distal to the ampulla of Vater, where the biliary tree inserts in the proximal duodenum. Now, because this is an issue that's exclusive to the GI tract, there's no respiratory distress, making it like esophageal atresia, but different from choanal atresia when we're looking at our three atresias. But making it different from esophageal atresia is the fact that the type of vomiting is bilious vomiting. As I said, the ampulla of Vater is getting into the proximal duodenum, and that's where the food stops. So when the vomit comes back up, it comes with gastric juices and bile and food, making a distinctly different type of vomit from esophageal atresia. The initial test is the abdominal X-ray. Now, the classic term associated with the duodenal atresia abdominal X-ray is going to be double bubble. Don't count on this being on the test, but if it's there, you automatically jump to duodenal atresia, and that's because you have gas in the gastrum, in the stomach, and then you have the pyloric sphincter, and then on the other side of the pyloric sphincter, you have some gas in the very proximal duodenum, but you have no more gas in the GI system. Because of that blockage, no gas ever gets into any of the ileum, any of the jejunum, none in the colon. It's all empty, so there's no gas. So none of it shows up exposed on the abdominal X-ray. You just have the little bit of gas in the proximal duodenum and a little bit of gas in the stomach, and that creates double bubble. There is one thing that you should think of, and it's either going to look like triple bubble or basically double bubble plus distal gas. Now when that happens, that's not duodenal atresia. Don't be tricked by double bubble sign with distal gas. If you see that, you should think volvulus, which is discussed in the second GI lecture. Here's an X-ray image showing you duodenal atresia. You can see the large bubble of the gas that's in the stomach next to a smaller bubble which is gas in the proximal duodenum. Now, to finish off our discussion of duodenal atresia, I'd be remiss if I didn't mention the strong association between duodenal atresia and trisomy 21, aka Down syndrome. The reason this is worth bringing up is that this can kind of throw a wrench in the way they present it to you on step 2. They can tell you the patient has Downs and then says they present with such and such bilious vomiting without giving you a great deal of other information, which, it could be volvulus, it could be intussusception, it could be other types of issues, but knowing that 40% of the patients with duodenal atresia have Downs increases that correlation, increases that association. You should really look into it. So you're getting an abdominal X-ray, finding the double bubble sign, really starts to lend evidence to the diagnosis of duodenal atresia. And then the last thing we should mention is management. Any case, man, woman, child, or adult, comes in with bilious vomiting. The first step in management is going to be IV fluids. The duodenal atresia isn't going to get corrected in one setting. It's not a medical issue. That is a surgical issue. So the first step in management when you're presented with the patient with duodenal atresia is making sure that their hydration and electrolyte status is normal. Pyloric stenosis is hypertrophy of the pyloric sphincter that separates the gastric cavity from the duodenum. This is not an atresia, which is why it wasn't included in the previous tables, but in fact it actually is more open at birth and becomes progressively tighter and more stenosed with age. That's why these patients tend to present after 3 weeks. Now, because of the fact that the gastric contents can't get into the duodenum, they can't get into the duodenum where the ampulla of Vater inserts and where bile is, they present with a non-bilious vomiting that's often described on your test as projectile. Another pathognomonic feature is this small olive pit-sized epigastric mass that's found on palpation of the stomach. It's non-tender, it's not painful, but there's an olive pit-sized mass. And there's another form of vomiting, intussusception, that also has a mass palpated on the abdomen, but is described as a sausage. So, and that's intussusception. So think olive pit, small mass, that's epigastric in region, that's pyloric stenosis. These patients also tend to present with dehydration and a contraction alkalosis and abnormal lab signs such as hypochloremic, hypokalemic, metabolic alkalosis. That's a contraction alkalosis. So pay attention to lab values when you're taking your step 2, because step 2 often tends to give you a ton of lab values. They'll give you a CBC, they'll give you the LFTs, they'll give you the BMP, but focus on what is relevant to the presentation. And if someone's presenting with lots of vomiting, you need to look at their electrolytes to see if they're abnormal. And if you see a low chloride, a low potassium, and an alkalotic state, that's consistent with contraction alkalosis, which is seen in profuse vomiting. And that immediately relates to the management you're going to do, which is IV fluids. And I highlighted olive pit here because it is heavily used on NBME exams as a way of signing that pyloric stenosis is the case. Contraction alkalosis isn't just relevant to pyloric stenosis, but it's important to any condition in which you have a lot of vomiting that leads to both fluid losses and metabolic disturbances. That can be an infectious process that leads to a lot of vomiting, or something like small bowel obstructions, and it's not just pyloric stenosis. And it's important to know contraction alkalosis for your test because there's different ways they can get at it. They can present a patient that has pyloric stenosis and then say, what 3 metabolic abnormalities are you most likely to see in this patient? And they're going to give you just columns of options where, one's hypokalemia versus hyperkalemia, and it's those little nuances that if you forget, you can get an easy question wrong. So we're going to create a diagram that underpins the physiology for contraction alkalosis, so you burn into your memory what the exact metabolic disturbances are in any condition with a profuse amount of vomiting. So it all starts with fluid loss. Any fluid loss that is primarily water is going to lead to a loss of extracellular fluid. Any extracellular fluid decreases are primarily going to happen without a lot of bicarb. Now, the loss of bicarb, without the loss of bicarb, and when the bicarb stays in your system, it ends up binding with the free-floating hydrogen ions. So a decrease of fluid without bicarb means there's a higher bicarb concentration. That binds to free hydrogen ions. The loss of hydrogen ions initiates the alkalotic state. And then when you have further fluid losses, this is going to activate in the kidney the renin-angiotensin-aldosterone system, which exists for the purpose of maintaining perfusion to the kidney. Now this works by, in the proximal region, it's going to dump hydrogen ions for the sake of retaining sodium and water, further exacerbating an alkalotic basic state in the blood. Now, if we add to this scenario something like pyloric stenosis, which means there's vomiting taking place, this is further going to exacerbate all the losses that we know. So in vomiting, you have a lot, gastric acid tends to be very acidic, which means it has loss of hydrogen ions. So vomiting leads to a further loss of hydrogen ions. Now we're getting more alkalotic. And also it contains a lot of potassium and chloride. So vomiting directly leads to the loss of potassium and chloride from the fluids that you vomit up. Now the exacerbation of all these hydrogen losses that's creating an alkalotic state means that down on the cellular levels, cells are actually going to start pumping hydrogen out of their cells to correct the acid-base status, and in doing so, they're going to take up potassium, which now is further exacerbating the hypokalemia that's going to start taking place. Going back to the renin-angiotensin-aldosterone system, aldosterone is a major component used to maintain blood pressure and perfusion to the kidney. It causes the distal dumping of potassium for the sake of taking up sodium and water. So you can see that it's a very complicated scenario that leads to the loss of hydrogen ions in many different ways that ultimately leads to a metabolic alkalosis. Remember, metabolic alkalosis is a high pH, high bicarb, and a compensatory high PCO2. And the frequent losses, as you can see with all the arrows, of the potassium and the chloride leads to hypochloremia and hypokalemia. So all this is to sort of underpin that in situations like pyloric stenosis or small bowel obstruction, a contraction alkalosis is a term that represents a metabolic alkalosis with hypochloremia and hypokalemia, with an elevated pH, an elevated bicarb, and a compensatory elevated PCO2. Now, to finish up our discussion of pyloric stenosis, the test, the first test you probably want to start with is an ultrasound. It's more diagnostic than an x-ray. Radiographs are mentioned, but they're not nearly as helpful as an ultrasound, because you could see this bubble here and it doesn't really clarify whether that's pyloric stenosis, maybe duodenal atresia, maybe nothing. So ultimately an ultrasound is going to be your best choice. And then obviously the first step in any management is going to be IV fluids, because you want to correct the electrolyte abnormalities, which can be contributed to by the contraction alkalosis we just covered. But ultimately you're also going to need to put in an NG tube to decompress the stomach. So that big bubble you see on the radiograph is air that's in the stomach and can't get past the pyloric sphincter. So an NG tube to compress the stomach, and it's largely symptomatic relief. But the long-term solution is you got to open up the pylorus, and that's with a myotomy. You got to basically cut the muscle open so the pyloric can open. And then here in this radiograph, note the distended gastric bubble, but there's no double bubble. The duodenal component that we saw in duodenal atresia isn't here, so it's just one single bubble. Now, the last topic to quickly discuss is going to be Hirschsprung's, a syndrome that's heavily tested in step 1, and there isn't a great deal more you need to know for step 2. It's just sort of the way you need to know it. Now, remember that Hirschsprung's is a congenital lack of ganglionic cells in the large bowel. Now, this is intimately related to all the clinical features that are important to getting the questions right in step 2. Now, the first is the buzz phrase they use to describe this feature in pediatrics is failure or delayed passage of meconium. Now, this can, if that's not caught by the mother, sometimes there can be like a little passage of meconium and that'll slide by, but the Hirschsprung's will get worse, and this can progress to a large bowel obstruction. A large bowel obstruction can present a lot like a small bowel obstruction. So you're going to get a distended, painful abdomen, vomiting, and you can get a metabolic disturbances from the profuse vomiting. You can get a contraction alkalosis. So abdominal distension is a main feature, and you'll be able to see that on an x-ray, which is your best initial diagnostic test, because if someone's presenting with a distended abdomen and pain from what could be a congenital Hirschsprung's disease, you start with an abdominal x-ray, because if you see distended loops of large bowel that go all the way up to the distal sigmoid or even the rectum, then you're suspicious of Hirschsprung's disease, especially in a child who might not have a questionable history of delayed meconium passage. But the most diagnostic feature is you have to see the lack of ganglionic cells. Otherwise, it could be perhaps a functional large bowel obstruction. You don't know if it's anatomic and at the cellular level. So the most diagnostic study is going to be a rectal suction biopsy. Now, this could be phrased in your test as biopsy, suction biopsy, rectal biopsy. It's unlikely that they're going to put two different types of biopsy on here, but know that rectal suction biopsy is the most correct of answers. The answer is not going to be a barium study. It's not going to be manometry. Those things can be helpful, but they're still inconclusive, because Hirschsprung's, by definition, is a lack of ganglionic cells. And so you have to see a biopsy that lacks the ganglionic cells to know that this is Hirschsprung's disease rather than some other functional issue. And then ultimately the treatment is that the aganglionic section of the bowel needs to be removed, and that can only be done through surgery.